Hi, everyone. My name is Vanessa Guzman. I am a second year family medicine resident at the Cleveland Clinic Family Medicine Residency Program, and I am here to share with you on a collaborative project between our program and the Obstetric and Gynecology Residency Program at Cleveland Clinic. Here is our agenda. A common complaint in pregnancy is low back pain with an incidence of 50 to 80% at any time during a person's pregnancy. In the PROMOTE trial, it showed that when OMT is added to the usual prenatal care, it slows the progression of back pain and functional deterioration during the third trimester. Similarly, in an article published in the American Journal of Obstetrics and Gynecology, in a randomized controlled trial, it showed that it slows the reduction in the function of a group with OMT in usual care compared to just usual care. When it comes to residency education, OMT often is not integrated into the care of pregnant patients. In a study done in a family medicine residency practice in South Dakota, they integrated OMT into prenatal visits. Amongst many barriers identified during their study, one was the lack of supervising faculty awareness of OMT applications in pregnancy. Family medicine training is broad and comprehensive that allows for more interface with different specialties. And osteopathic physicians are overrepresented in family medicine often, making us the perfect group to lead education on the integration of OMT in other specialties. Utilizing an existing partnership between family medicine and OBGYN residencies at Cleveland Clinic, we wanted to assess the attitudes and comfort level of OBGYN allopathic residents with OMT and expose them to osteopathic treatments applicable to the care of pregnant patients. In a 2-hour session during the OBGYN resident didactics, we lectured on the basics of assessing somatic dysfunction, as well as introduced residents to techniques commonly used in the low back pain treatment in pregnant patients. For each technique, we would demonstrate the technique and then split into groups to practice them on each other with table trainers to assist residents. To assess the residents on their attitudes and comfort level with OMT, we did a pre and post session survey. A total of 12 allopathic residents participated in the survey, all at various stages of their training. Our pre and post session survey was composed of 9 total questions focused on attitudes and competency on OMT. Our goal was to enhance allopathic residents' exposure and comfort with osteopathic manipulation, and to provide training in common osteopathic treatments used in the care of musculoskeletal pain in pregnant patients. Here are the individualized scores of each participant. The green bars represent pre-session scores, and the purple bars represent post-session scores. Notably, each participant's post-session scores improved. When taken cumulatively, total participant scores pre-session were on average of 27.58, with cumulative total participant scores post-session were on average 37.58, a almost 10-point difference. To determine if this difference was statistically significant, we ran a Wilcox-signed rank test of the data, and with a p-value of less than 0.005, the data was statistically significant and concluded that our hypothesis was indeed valid. With this project, we were able to conclude that OBGYN allopathic residents appreciate OMT as a complementary treatment to pain in pregnant patients. They are also interested in further OMT education and its application to their specialty. Most notably, OBGYN residents have key manual skills inherent to their specialty that allow for easy translation to osteopathic skills. And of course, family medicine serves a crucial role in helping integrate OMT education in partner specialties. Some limitations of our study include a small sample size limited by residents scheduled for didactics during our session, a focus on OBGYN specialty, and of course a single educational intervention that followed immediate post-session assessment, missing the longitudinal component on the education given. Future directions include booster sessions to reinforce gains made during this single session intervention, also to identify whether education of OMT translates to changes in clinical practice, and possibly identify champions within the OBGYN residency that can promote OMT in clinical practice. These are my references. Here is my contact information. Thank you.